This is a case of tuberculosis neck abscess. The patient is a young male, about 25 years old, presented with a swelling over the lower part of the neck. This is the swelling just about the clavicle, supraclavicular area. Swelling was not tender. The skin over the swelling was normal. Patient did not have many of the acute inflammatory symptoms. On examination, the swelling was soft, fluctuating, and that revealed underlying fluid. Now, patient did not have any acute inflammatory signs, and these swellings are known as cold abscess, which is typical of tuberculous abscesses. These cold abscesses in the neck are very common in our parts of the world, that is in Asia, particularly in India, Pakistan, and most of them are related to underlying lymph nodes which are involved in tuberculosis, and these underlying lymph nodes, they get liquefied and ultimately they form abscess. The lymph nodes are in the deeper part of the neck. They are deep to the deep fascia, but the swelling, when they present, the swelling is very subcutaneous. The reason for this is that the lymph nodes, they become liquefied and they penetrate through the deep fascia, and they ultimately perforate the deep fascia and come to lie more superficially in the neck, just beneath the skin, and these are known as collar stud abscess. Collar stud abscess. The lymph nodes are deeper in the deep to the deep cervical fascia, but the abscess is very superficial, and something like this. That's the deep fascia of the neck. The lymph nodes are present here and they become liquefied, form an abscess, and this ultimately perforate out through the deep fascia. That's the skin, and the abscess becomes more superficial. That's the abscess, and they are present as a subcutaneous abscess. They are ultimately, if nothing is done, this will perforate through the skin and will come out of the neck and form a non-healing discharging sinus. And this sinuses leaves a very ugly scar, and they become most of the time multiple, and they form very bad, very awkward cosmetic appearance if not treated properly. Now, most of these patients, they have got a family history of tuberculosis. Someone in the family has been treated in the past for tuberculosis, and a chest X-ray is very essential. And if you look at the chest X-ray in this young male, there is evidence of pleural effusion. There is evidence of this opaque fluid collected in the left hemithorax and just on the lateral part, the lower part, and this is the pleural effusion. About 30% of neck abscesses, which are tuberculosis, they have got some evidence of pulmonary tuberculosis when the X-ray is taken. This is pulmonary pleural effusion. But this patient had no signs of and related to any respiratory system. He was not coughing, he was not having difficulty in breathing, and this was a surprise finding. So anyone who is suspicious of having a neck tuberculous abscess should have a chest X-ray to rule out concomitant pulmonary tuberculosis. Such neck abscesses are superficial and they can be drained without any G anesthesia. They don't require any general anesthesia unless the patient do not consent for a local anesthesia. Now this is the post-operative X-ray, post-operative picture of this patient. You can see a small scar over here. The abscess has been incised and drained, but the post appearance of the abscess is not completely gone. There is still some residual collection left behind, and after incision and drainage, the patient had a recurrence of the abscess and which was drained spontaneously, and then ultimately the swelling disappeared. The pus was about 80 to 100 cc of pus over here, which was ultimately drained. The pus was sent for culture sensitivity and for microscopy. The very first specimen of the pus, when the pus smear was done, it revealed AFB, acid-fast bacilli, and that confirmed that this patient had tuberculosis. The pus should also be submitted for TB culture. The TB culture takes about 4 to 6 weeks for reporting, but once you have seen AFB, acid-fast bacilli in the smear, the treatment should be started, and the treatment should be at least 4 drugs to start with. We usually give them rifampicin, pyrazinamide, ethambutol, and INH. These 4 drugs are started depending upon the drug weight days, depending upon the weight of the patient. First, the patient is weighed. It's very important that a tuberculosis patient should be weighed properly, and the drug should be doses should be according to the weight of the patient. Most of this TB lymphadenitis in the neck, once you start treatment with the regime, 4 regime, they heal up very rapidly. They do not require any excisional surgery. They go on towards healing, but off and on during the healing processes they may form recurrent abscesses which are not to be worried about. The abscesses can form, but they usually disappear with the passage of time. The treatment of extrapulmonary tuberculosis may last longer than what you give for pulmonary tuberculosis. most of them would require treatment for at least 9 months before you can completely say that they are cured. Once the treatment is started, they improve. They start gaining weight. Their symptoms they disappear. What is important is follow up. They should be followed up for a couple of months, and regular follow up will prevent a recurrence of tuberculosis.